we get in to repair some of these valves. Because we go in there with the thinking that if you repair and it fails, then you have to bring back the patient for replacement, and there's no money for that in most of our countries. A patient has just one chance. So as you are going in, you are just thinking, your mind is more or less on that one single chance that this patient is likely is going to have. So most of the times we have this mixed feeling. Do we repair? Do we replace? We just say, oh, if you repair, maybe it will fail and you need to bring back this patient to the theater. So I think our colleagues from Ghana and Nigeria will elaborate more on this. Thank you.
I think these comments, Hani Najm from Cleveland, are really important. It depends on your practice and where do you practice. Is actually reoperation on a mitral valve a failure of your repair? And I would always say if you repair a newborn and an infant baby that lasts for 6 months, that's actually a successful repair, believe it or not. Why? Because you allow patient to get out of that critical neonatal period, and you can actually come back to this valve again. So reoperating on a failed repair is not a major thing, especially that we know now redo surgery up to 6, 7, 8 times is safe. We could do this, especially if you do certain procedures to make sure that you're not stuck to the sternum, you close the pericardium, do all these. So buying some time before the patient, as the patient or the baby or the child is growing is actually a good thing. Avoiding anticoagulation. Mind you, every time a valve failure comes back, they come back slowly and they come back in reasonable shape if they ever, obviously, depending on the availability of money and access. But if a valve, mechanical valve gets stuck or thrombosed, they get a stroke, they are in cardiogenic shock before they reach to you, and they probably never reach to you. And that's why I'm saying we shouldn't be thinking about a reoperation on a mitral valve after a certain number of years is a failure. As my mentor, Bill Williams from Sick Children, was saying, everything fails. It depends on how long you follow it up, even mechanical valves. Everything fails, regardless. So not every reoperation on a mitral valve is a failure. Sometimes buying 6 years, 5 years, 10 years in an environment which is even restrictive is a good thing.
I certainly agree with you, Dr. Hani Najim. I think in a small, because you have a different age distribution for the presentation of rheumatic valves. We have had rheumatic lesions even at the age of 6. It's surprising, but it is true. They even present at that younger age. So in this group of patients, I certainly agree. Any attempt of repair is still the best option to give some time until you reach a point where you can replace the valve. Then again, it all depends on the in an older patient. If you can put in a good sized valve and the patient is responsible taking the anticoagulation, then we can probably still consider replacement as the first option, but it has to go on case by case basis. I totally agree with you.
Thank you. A 9-year-old boy presented to our hospital with severe mitral regurgitation plus severe tricuspid valve regurgitation with NIA class 4, generalized body edema, hepatomegaly. We assessed the boy. It is secondary to chronic rheumatic heart disease. We planned the surgery. We take him to the OR, and I repaired the valve. With the same techniques that I mentioned before, I repaired the mitral valve. And either to say fortunately or unfortunately, I don't know, there was one ring in the whole country with 120 million people population. There was one McCarthy 3-dimensional ring was in the hospital for tricuspid valve. So I picked it up and I put it in the tricuspid valve, 30 millimeter ring. Then the post-op course was smooth. Patient became fine. But the echo in the ICU said there was mild mitral regurgitation. We were fine with that. There was mild tricuspid valve regurgitation. We were fine with that. 2 weeks after, patient was discharged to his home. After another 1 week, patient came back to the hospital. This time he came with severe heart failure, jaundice. He has gross hematuria. He was urinating all his blood. Patient was having hepatomegaly 8 millimeter below the right costal margin. So we assessed this patient. We again do echo. There was still mitral valve regurgitation. It is eccentric actually. So by definition, all eccentric mitral valve regurgitations are severe, but the volume was not that much big. So we were not worried about it. So we tried to investigate all the hematologic investigation. Patient was sent to the hematologic center. They did every possible hematologic examination. They didn't find anything for the hemolysis that he's having. Finally, they returned back the patient to us, saying that it is a vascular hemolysis. You have to deal with the valve surgery that you have performed. Then we again admit this patient, started giving him blood transfusion because all times his hemoglobin is in the range of 6 to 7. We transfused him 22 times in 3 months' time, and his hemoglobin was hardly ever above 9 milligram per deciliter, 9 gram per deciliter. Finally, I decided to take him back. We have to do something. We have given him a 6 weeks course of infective endocarditis course in case of indolent infective endocarditis treatment, but that doesn't bring anything different to the clinical scenario of the patient. We took him back again. So in 3 months' time, this 9-10 years old boy must be subjected to another heart surgery. So I did the redo. Hopefully, luckily everything was successful. So I went back again and I replaced the mitral valve. And I opened the right-sided, I explanted the ring. What I found on the ring was there is still a raw surface in the septal margin in the septal side of the ring, while the other side was almost covering with his own tissues. But still, because of the regurgitant from the ring, there was a septal side, there is still a raw surface. So I explanted the ring and I just used only suture technique to repair the tricuspid, and they came out. You know what happened? No hematuria, starting from bypass, weaning him from bypass. The jaundice disappeared in 2 days. The hepatomegaly came down in 5 days. His hemoglobin, he didn't take even a single unit of blood. His hemoglobin became 12 grams per deciliter for the first time in 4 months. Everything fine. We discharged the patient. I spent a very horrible 3 months time in my life, but finally it paid off. But there was a question on my mind, I should have re-repaired this mitral or not. I will leave this for the floor. Thank you.
I think your mistake is to use that type of ring. That's what I said at the beginning. Don't use an adult size ring in pediatrics, because that's what it is. If you get a jet from a minor, even mild MR or TR, is going to hit that heavy fibrotic ring that is going to hemolyze. So use bovine pericardium, you never get hemolysis with it. That's what I'm saying. It is exactly that.
Congratulations to you for having done a valiant effort to get that patient off. But I think in a setting of heart failure in New York Heart Association class 4, these are the patients that are the highest risk and have, high mortality after the surgery. But despite that, you managed to get the patient through. You should be proud of yourself.
Thank you very much for your very brilliant talk. My name is Uvio Nakboya. I'm from Nigeria. In Nigeria, we have to place our patients in the proper context. And the context is not just straightforward rheumatic heart disease, but rheumatic heart disease in the setting of extreme poverty. And in the general scheme of things, no health insurance. So the problem is not coming back for reoperation. The problem is that the patient will not be alive for a reoperation because he or she the parents take about 6 months to 1 year from diagnosis before they can raise the money for the first surgery. So your first surgery has to be the right surgery that will be of the best duration or the better duration between repair and replacement. And most of our patients come as Carpentier type 3. So the outcomes of repair, even in very good hands, are not very good, not very durable for our very young population. So our patients come in very early. And I remember 2 instances, I'll just say them very quickly. The first one was a 15-year-old girl. When we were starting our program, my trainer came from Israel, and he's very good with mitral valve repairs. And he did a mitral valve repair for her. She had rheumatic heart disease, but just mitral regurgitation. So he did a very beautiful repair. Post-operative echo was perfect, no regurg. Now she's back to us with severe regurg just 5, 6 years after. She needs a surgery. She's taken almost 2 years from diagnosis to raise the money for another surgery. Now, in our setting, those are the kind of patients that we see. So we're not having problems with having a redo surgery, but the patients will not be there for a redo. And since the replacement is longer lasting, and that's why for most of our patients in Nigeria who come with rheumatic heart disease in the young population, replacement is what we do. I think the youngest I've replaced is a 12-year-old who came in with Lusenbacher syndrome. So we had to do the replacement. She's 3 years down the line now. She's no issues with, no problems with her because we're seeing her regularly. I'm sure the Ghanaians have a longer experience with these patients. Thank you. Well, I think that is probably what may have happened.
Not an argument. You know, mitral valve repair has been proven in every single series that gives you a better outcome than mitral valve replacement, particularly in children. So if the valve has got a chance to be repaired, you should repair it. And if your experience does not allow you to do a good mitral valve repair, then maybe you should refer the patient to someone who can do a good mitral valve repair. But whatever happens afterwards, you don't have any control over. You know, a mechanical valve can thrombose. It's the same thing. You know, you go and repair you spend whatever in the hospital for a patient, and then the next day a car accident happens and the patient dies. We don't have control over these things, so we should do the proper thing to the patient.
If you don't mind, just a short question because we are
okay. It's comment. It's Hisham Shauki from Cairo, Egypt. Speaking about repair or replacement, it's a long-standing discussion. Replacement, it's an easier surgical procedure, but you have, as Dr. Zuhair was saying, you have thrombosis, you have bleeding, you have psychological for the baby. So I still think that doing a repair is the right thing. The problem is colleagues here asking that learning a repair, and they chose the worst scenario to learn the repair in, which is the rheumatic heart patients. This is the most difficult and most challenging, but still I think it's doable. You have to try your repair. Of course, the patient with hematuria postoperative, as Hani said, it's due to the jet in the ring. So it's, I think, if there is no mitral regurg, if he just took the ring out, the baby will be fine. So it's a jet lesion. And the last point is, it's as I said, it's the most difficult. And we have to know that rheumatic fever affecting the heart is a spectrum, and it's not something fixed. So rheumatic fever, rheumatic valvular mitral valve is different in different areas. I think one of the very important thing is using the prophylactic penicillin before the operation and after the operation, because this is I think this helped a lot. For a simple example, in my country, The still we have rheumatic fever. We have around 300,000 patients with rheumatic fever. But the good thing is it's mild, very milder lesion because we used prophylactic anti-penicillin. And the way we use it in Egypt is a bit more aggressive. We don't use the international point of using it every 21 or 28 days. Actually, we use it every 15 days. And we use it before the operation and after the operation. So now we still have some rheumatic fever, definitely, but it's milder. We don't see the very aggressive valves that we've seen in the video here. We're just seeing the annual dilatation. And the number of rheumatic patients who operate annually, in the pediatric age group, went really down in the last 20 years. So I think it's a national program rather than it's a personal thing. Thank you.
Thank you, Jazzy. One very short comment. I think we need to change the way that we think about this, and I agree 100% with our president, Zohair Al-Alis. You know, when a valve repair fails, it's the surgeon's failure. But when a valve replacement fails or the valve clots, it's, you know, we blame the patient or we blame the valve, and we have to stop thinking like this. If we practice medicine based on what might happen tomorrow, we wouldn't do anything. In fact, if you want to save money, just don't do any operation at all. That's the cheapest operation you can do. So, you know, taken to the extreme. So I really agree with Zohair's sentiments. The whole point about these meetings, and it's great to hear these experiences, is that you got to go back and say to yourself, well, what am I going to do differently? Or what did I come to Marrakesh for? Or am I just going to do the same thing until the next meeting? Thank you.
So would that mean that any patient with rheumatic, 100%, it's only a repair? No, sorry, I'm not trying to.
Actually, the last slide that you put up saying that about a good surgeon and excellent surgeon, it should be also that a good surgeon or an excellent surgeon should understand which valve should not be repaired. You know, because there are limits for everything.
Sure.
Can I raise an issue? Can you hear me? This is very important debate, and I'm sorry it's taking so much time, but it is important to go in depth. We feel, I agree almost 100% with you, but not 100%. The issue I want to bring in, if I'm the parent of that child, I like to be informed of the two options. I like to be part of the decision. Do I want to risk a thrombosed valve, but no reoperation potentially? Or do I want to go for a repair that may fail? I mean, both of them can fail, but to what extent is there a role for the parent to decide between two options that neither one is 100% perfect? I certainly know in Canada that I inform the parents that even if there's a lesser good option, I still inform them about that option. And they tend to play a certain part in the decision process. And I don't know in other parts of the world, this is kind of an ethical issue, but to what extent do we tell the family, I know best, this is the best option, or do I tell them there's two options, I believe this is the best one, but there's another option, and give the parents a chance to perhaps be part of the decision?
I think, Christo, in this part of the world, I think almost, I would say more than 90% of the parents would put the trust on you and put the burden on you for making the decision.
Thank you, Siva Kumar, for the excellent presentation, and as you have seen, many comments and questions. Now, I will call Sachin Talwar. Sachin, are you here? So when we cannot repair, then we should replace the valve, and Sachin Talwar will talk about pediatric mitral valve replacements.
At the outset, I would like to thank the World Society for having me here. I'm going to take the easier way out, and I'm going to talk about the replacement. So my job is cut out. Everybody has spoken about the repair, and I just need to talk about the valve replacement. And that makes it pretty simple. How does it work? How does this work? So, I will not only be talking about the rheumatic mitral valve replacement, but I will be talking about the replacement of the valve in the pediatric age group. So, that will cover the rheumatics as well as the non rheumatics. Okay, so there we go. So the topic is mitral valve replacement in the pediatric age group. Now I have no disclosures. The presentation outline would be why and when, then with what, how, the tips and tricks, the technical issues that we face, the adjuncts, the problems, the early and the late results, and the conclusion. So I would skip up many of these topics because we've been discussing them ad nauseum. So I'll just concentrate on the broad things. Now there is a lot of paucity of data about the results of the mitral valve replacement in children. The alternatives to a competent mitral valve and preservation of the left ventricular function, and this is typically more importance of patients who have got no pulmonary arterial hypertension is you take a single ventricle path. Now, this is particularly important in those patients who have a single ventricle physiology and significant mitral valve disease and the heart transplantation. Particularly many patients with mitral valve regurgitation, single ventricle physiology, they will end up getting a transplant. So then why choose mitral valve replacement instead? So it gives a better probability of survival. Now I'm talking about having a competent mitral valve. Now whenever repair is possible, there is no doubt that is the best option. But when you are confronted with a patient in whom a competent valve is definitely needed, why would you choose it over a single ventricle path? So there is a better probability of survival. So now this is not a comparison with the repair. So that is a comparison with putting a patient on the single ventricle or a transplant. Then a second replacement is very safe and the functional outcome is satisfactory. Now, what's bad about the replacement? Now, we all know that the repair has got the better ventricular function. The small cell valves are still available. They started coming up. The supraannular mitral valve replacement has got the high LA pressures and poor outcome. The thrombosis, infection, heart block, and bleeding, they are definite concerns. There is no growth potential. And then the pediatric MVR has a high operative mortality up to 30% and a very unfavorable long-term outcome. And the 5 and 10-year survival has ranged as low as 50% to 80%. So the questions now that need to be answered are, what is the risk of MVR? Can the risk be predicted at MVR? This is the risk of second MVR, the morbidity and mortality of a second replacement, then the effect of the replacement on the growth and the annulus, and does the somatic growth influence the risk of the second replacement? The challenges are in this age group, the small patient size. Mind you, we're talking of a patient which is less than 15 years of age. The risk of thromboembolism, the need for somatic growth, and especially in patients less than 2 years of age, this becomes a real big issue. But sometimes you are confronted with a patient who has had multiple reoperations, like Dr. Hani was saying, you had a repair 2, 3, 4 times, but you've not been able to do anything right. So ultimately, you end up doing a replacement. So now it becomes a big challenge in itself. So when the valve replacement is inevitable, now I am again and again not going towards repair. My whole presentation is on the replacement, so I will concentrate on that. So when it is inevitable, you have the choices of the mechanical valve, the bioprocesses valve, the stented bovine internal jugular vein or the Meredy valve, the Ross mitral operation which is now coming up, and then the allograft, which we have really used in a few subset of patients. So if you take a look at the mechanical valves, the advantages are the structural degeneration is rare. The disadvantages are you have hemolysis, infection, thromboembolism, bleeding. The choice of the mechanical valves. Now if you see the chronological order in which the valves have evolved, the brown shows the older valves. The Star Edwards valve, the VL valve, the single leaflet valve, the Omniscience, and the Yorkshire. But all of them had their own problems. They have been gradually phased out. Many of them were high profile. The thromboembolic complications were very high. There was a very high incidence of stuck valves. So that led to the concept of the bileaflet valves. And then we came the St. Jude Medical, which came up with very small valve, the carbomedics valve, the ATS valve. Now that is also being phased out. And then you have the latest mechanical valve, the Onyx valve, which people claim has required to be a very, very low dose of the anticoagulation. The other alternatives, of course, are the bioprocesses and the Melody valve. So very, very, the something which is now has also been used is been the mitral homograft, and it has the very, very poor results. We had published a paper of 27 patients, except one. All of them came back with for a reoperation within a year or so, and the results were extremely poor even after perfect operation. So I don't think in the current day practice the mitral valve homograft has a definite role, except in patients on whom the disease is on the tricuspid valve and they come with endocarditis. So in the mitral position now, it is practically not accepted. Then the ROS2 is emerging and is highly selected older children. Mind you, the ROS2 has got the problems that the pulmonary autograft is susceptible to rheumatic valvulitis. So in the rheumatic population, it is not a suitable option. But if you have the patient with mitral valve disease, which is non-rheumatic, then yes, it is an option. And then the aortic homograft in desperate situations like endocarditis, it may be used. We have used it in around 5 patients, and that the implantation technique has been similar to that of the ROS2, but it has given us around 4 or 5 years. It has bought time for us till the endocarditis is over and the patient has grown up, and then we have ended up getting a mitral valve replacement. So technical considerations, regular bypass, that's pretty routine. Hypothermia, sometimes real short circuit arrest, regular aortobicular cannulation, selective cannulation when you're planning to go transeptal, preserve at least the posterior apparatus if possible. Now we believe in the complete caudal preservation, and in the video which is coming up, it's a practically standard mitral valve replacement, but it goes on to show the extent of the disease in the rheumatic who is young, and also shows the technique of the complete caudal preservation. And then, of course, whenever you are dealing with a patient who has endocarditis, then all the mitral valve tissue should be excised. The other important thing is you avoid the plagets as much as possible. We do not use the plagets because if you use the plagets, you end up putting a smaller valve, and then if you have the plagets, there is a excessive reaction to the plagets, and then you have a higher pannus formation and late stenosis. So this is really a trick. In the rheumatic valve, the annulus tends to be pretty thick. It tends to be calcified many times, and the platelets are not required. Now, this is in sharp contrast to patients who have the congenital mitral stenosis, where the cusps are thin, the annulus is not as tough, and so the use of the platelets is required. But in the rheumatic, you can get away with this. Now, this is a video. Now, you see, this is a 12-year-old patient, and you will see that the valve is heavily calcified. Now, what we have done is we excised the mitral valve. We're going to put the commercial stays, and then the caudal apparatus is going to be preserved. See, look at this valve. It is so heavily calcified. You might feel that this is the valve of a 35-year-old gentleman, whereas this is not the case. Now, the chordae is being preserved, the anterior chordae is being preserved using the Wspchs technique. Now, here the trick is to debride as much of the valve as possible so that the pannus formation doesn't occur, because ultimately the size of the valve which you're going to place is not going to be very big. However, we still believe in putting a larger size valve because it avoids a reoperation. So the next frame is going to show you how you can place a bigger size valve. Now you have done the complete anterior caudal preservation, then it's time to excise or incise the posterior caudal leaflets, and the idea is to shave it off as much as possible, make few cuts in the annulus, and when you make these small cuts, you may be able to place a bigger size valve. Now here you will note that the papillary muscle is split down all the way down to the base of the left ventricle so that you avoid the left ventricular outflow tract obstruction. Particularly when you have a big valve, and you have the complete preservation of the chordae. And now the posterior leaflet is being completely shaved off, and then you have a lot of minimized the tissue, and then you make slits across the annulus. Now this is going to enable you to pick a bigger size valve, and you see that this is going to take a 25 size valve, place the valve in a routine fashion. It's a St. Jude mechanical 25 valve, and having placed the valve, now in these children the myograph protection is a real problem in small kids. So what we will do is, as soon as the valve replacement is completed, we'll put a Foley's catheter across the mitral valve, release the aortic cross clamp, and then the heart is beating, the left atrium is open, and then the heart is de-aired, and the mitral valve is completed. So this is how we usually do, and we are able to place a bigger size valve and minimize the aortic cross clamp time. So now the St. Jude has come up with a 15 size mechanical valve. Previously you used to have an Abbott 15 millimeter valve. Then the St. Jude valve 15 millimeter valve is the latest valve, and then the latest in the armamentarium is the Onyx valve, which requires a very, very low. And when it came in the aortic position, people were using only aspirin, and they were not using the warfarin, and the same results have not been extrapolated to the mitral position, but they could be. So now the contrary arguments to a larger valve. So there is always a bias to put bigger valves. So what are the contrary arguments are? The large valves can produce the complete heart block. They can produce the compression of the left circumflex coronary artery. Then they limit the growth of the annulus, and then they will produce the alveolar obstruction. And one of the methods which I showed you was the complete splitting down of the papillary muscle, all the way down to the left ventricle. Now, what is patient prosthesis mismatch in this group? Now, this is inevitable, and instead of defining the size of the patient with the size of the prosthesis, it is a good idea to measure the transvalvular gradient across the mitral valve. And if the velocity is more than 2.2 meters per second, then you are dealing with a patient prosthesis mismatch. And one of the strategies which has been proposed is the method of a supraannular MVR, but it has its own problems. It needs a higher level of anticoagulation because a part of the prosthesis is coming into the LA. Then it can produce obstruction of the pulmonary veins, and sometimes, very rarely, it produces the heart block and the alveoli. Although the prosthesis is lying in the left atrium, the bioprosthesis is a last resort, and it is to be avoided as much as possible. The other problems is that are very, very high profile, and they are not available in the small sizes, but sometimes you're pushed to do this. In a 14-year-old girl who later on wants to have pregnancy, wants to buy time, you end up putting a small bioprosthesis. But the interesting part is we think that the bioprosthesis has no penance deposition, but it actually does. And what happens is there is a fibrous reaction of the pediatric age group patients to those leaflets, the bioprosthesis leaflets, and that leads to formation of the pannus. It leads to calcification of the leaflets, and then that ultimately leads to a deposition of a thrombus, which is, you might be surprised to know, but it has been documented very clearly in a large series of patients in whom the bioprosthesis valves were used. Now, coming back to the latest edition is the Merody valve. Now, it is a bovine internal jugular vein, which is stented. It was primarily used for the pulmonary position, and now it is pushed in a reverse position. The Boston group has popularized it, and it is a stented bovine jugular vein, and it can even be placed across a small mitral annulus, and then it can be expanded as the child grows and offers a large effective orifice area index for any given diameter, and later on you can go and have a replacement. However, the problems are that it is projecting into the left ventricle, so you can have the alveolar obstruction. The expansion of this valve, once you do, it can result into the coronary obstruction, and the thrombotic risk of this valve is unknown. Till now, there is no data about the thrombotic complications. Now, this is the placement of a Merody valve. Now, please remember that this is a pulmonary valve which is placed in the upside down position, The valve is being prepared, it is trimmed, and then it is going to be, it is just tested, and now it is going to be sutured to the mitral annulus. So you resect the mitral. Now this is a patient who had congenital mitral stenosis, and you can see the tissue. It has the bulky tissue post AV canal. Now here obviously it is an impossible task to preserve the chordae. You completely resect the mitral valve, and just some amount of the chordae can be preserved, not major. Then the valve has to be inverted upside down into the ventricle, and one has to be careful that the valve has to be inverted. Now, otherwise, you have a serious obstruction because this valve is going to flow in one direction. So, the pulmonary valve is there, so it has to be placed in a reverse direction. Now, because this patient has got a AV canal, the annulus is thin, therefore, you end up putting the pliers, and that will lead to the undersizing of the valve. Now, having placed this valve, the valve is very small, it has gone inside the LV cavity. You will need to dilate the valve at the first time, otherwise, you will not be able to have the expansion of the valve. So, once the valve is being tied, now you can see here that the sutures have been placed, the valve has been inserted into the left ventricle, the sutures will be passed through the ring, and you can see that normally when you're talking about the pulmonary valve, the ring is going to come upside down. Here it is placed in a manner that the unidirectional flow is maintained. And now once you are suturing it, you will tie it, and then you will insert a catheter across it. And how is it going to get fast forwarded? Now I'm not able to. Oh, so now you place a small balloon across the melody valve, and you gradually dilate it, taking care not to disrupt the leaflets. And once you have dilated it, then you will test the valve for the competence. And in the follow-up, this can be done per quick. Now I'm going to maybe take a couple of minutes extra because there is one more video of the Ross mitral. So now once this is done, the left atrium is augmented using a bovine pericardium. Now this can be a very, very important step in these patients. So advantage of the melody valve are it avoids the warfarin, and there is a potential for late dilatation by a balloon. However, it produces the definite LV obstruction in 20% of the patients, and then there is the unpredictable response of the pediatric patient to bioprocesses, and in young children, there is the accelerated stenosis. Now, this is a very interesting thing. There was a report which was published on the use of the inverted mitral valve in the aortic position. Now, if you see this picture, mitral valve has been inverted and it has been placed in the aortic position. But we regularly do this. We use an Onex aortic valve, which we reverse and we put in the mitral position. And especially when you're doing the, let's say, 13 valve or 15 valve, it seems to work very well and buys you time. Now, the ROS2 operation is mainly done for the older children and young adults. So, we are talking about the pediatric valve replacement here. So, in small infants in whom the valve is non-rheumatic, you do this procedure. The growth potential is, however, doubtful. And the problem is single valve disease, you treat it for a two valve disease, and we have a very limited data on the outcomes. Now, this is a very interesting video, and you'll see this technique is totally different from a traditionally described Ross mitral. So, first step is the harvesting of the autograft, which is in a regular fashion. What you will observe in this video is a different method of implantation into the left ventricle, and that leads the possibility of the growth. As a lot of people, they place this valve inside a tube made of a graft and then they implant the left atrium. The problem with that is there can be obstruction of the pulmonary veins and the valve does not grow. In this technique, where we do not do that, there is a possibility of that the valve doesn't grow. In our center, we have done close to 30 patients and 5 patients in the pediatric age group, and we have observed that at follow-up, these patients are doing very well. So first you test the autograft. Now the valve should not be bicuspid. So this we are using mainly in this. We have used these patients the valve for patients with the AV canal and non-rheumatics. Obviously, in patients more than 35 years of age, we use that for the rheumatic also. Now, what you need to do it here is the annulus of the native valve. You have to stitch using a continuous suture, and you have to invert it all the way down into the left ventricle. Now, having done that, then you will again take it out, and then you will create a collar of Teflon, which is in the form of 3 U's, and then you will suture it in such a way that the valve is caged around those Teflon, and in between you have a chance for the. I just going to take 1 minute more. So therefore, the valve can grow, and now this is a completely different concept as that of placing the valve in a tube. Now you see that the valve is going to billow between the two pillars. So with the passage of time, it is very much possible that this valve can grow. And this is very important in the pediatric age group. For a patient who is, let's say, 35, 38 years of age, you already put in a bigger valve. So growth potential is not an important concern. But for a pediatric patient, yes, definitely it becomes an important issue. Now, following this, you test the valve for competency, and you'll find that the valve is nicely competent. Now, in the past, in 1966, the aortic home graft was described for replacement of the mitral valve in dogs. But we have been using this in very, very desperate situations in patients who have got the endocarditis. The technique has been similar to that for the ROS2 procedure. Now, the predominant mortality which was observed is for patients with the deteriorating ventricular function, endocarditis, PPI, and precursor, the AV canal, Schoen complex, and then the patient processes mismatch. And the risk of the, I'm just going to speed through. The risk of the second MVR is with a longer follow-up, the fibrosis because of the response to the valve, and then the ongoing attrition because of thrombosis, reoperation, need for transplant, failure to preserve the subvalvular apparatus, cardiomyopathy, and secondary to long-standing mitral valve disease. Now, own experience, we have done around 138 patients of less than 15 years of age. In the last 19 years, it's 106 rheumatics, 32 congenital lesions have been mainly mitral regurg in 79 patients, mixed lesions 59, early deaths 19.6%. That's very high in this subset. In the rheumatics is less than 1%. The follow-up has been close to 8 years and 19 reoperations, that is 14% reoperations. So that is very important. And then the results from around the world show that the results are very poor in this age group. However, some studies have given the acceptable results of the 15 size mitral valve replacement, a 40-year experience showing the acceptable results in this group from Indianapolis. And then this is a pediatric consortium study which shows the acceptable results. So what you need to do is you need to have a patient-specific approach to mitral valve replacement in children, especially in infants weighing around 10 kilograms. So to conclude, the results of the mitral valve replacement in the pediatric age group are vastly different. There is the significant morbidity and mortality in patients less than 5 years of age. Results are better after 15 years of age. They're better in the rheumatic population. There is a significant risk of reoperation. The thrombosis and bleeding are major issues. The ventricular function deteriorates in most over a period of time. The heart transplantation is a real possibility, and the continuous follow-up is mandatory. Thank you very much.
Thank you, Talva, for a great presentation and a lot of wonderful illustrations. Because of time, we may not be able to take questions. We may be able to interact at the end of the session. Thank you very much.
Thank you.
We'll now listen to Abdelmalek from Algeria presenting beating heart mitral valve surgery.
Bismillahirrahmanirrahim. Dear colleagues, dear Drisi, thank you for your invitation. Thanks for the World Society for allowing me to present this topic, which will be in the mood of the session of today, controversies. It's a controversy will, I'm sure, provoke a lot of discussion. The practice of cardiac surgery in developing countries encounter a lot of difficulties. Lack of centers, insufficient qualified workforce, and very insufficient financial support. That's transformed an ordinary activity in this field as performed in the developed countries in a daily challenge for local teams in developing countries. The situation becomes more complex when these teams have to deal with more difficult situations, like in patients with left ventricular dysfunction, especially in emergency. These situations with no possibility to have any kind of circulatory support lead to a very critical results in terms of mortality and morbidity. It seems logical to search the less aggressive approach towards the left ventricular function already altered. Ischemia perfusion injury is well known as a consequence of cross-clumping on cardiopulmonary bypass. In this context, a beating heart surgery with no induced ischemia appears to be a reasonable option. Then why heart beating surgery? All these studies discuss the effect of cardiopulmonary bypass on beginning inflammatory syndrome, lesion syndrome, on the fibromyocyte, and on the left ventricular function itself. This goes to dysfunctioning the left ventricular function in the systolic and diastolic function. And it seems that this dysfunction is not only due to the edema provoked by the inflammatory syndrome, it is more due to the ischemia, due to cross-clamping. So if the ischemia is the major cause of dysfunction, why we can't avoid it simply? The next question is really a heart beating surgery efficient to reduce myocardial ischemia perfusion injury? Theoretically, yes, but in the real life, that is not another question. This study, which was a randomized study with two groups comparing for coronary surgery between on-pump and off-pump with no cross-clamping. And what's the conclusion of this study? There is no difference between cross-clamping and no cross-clamping on ischemia, on dysfunction. So is it true? Here we are another study. We say the opposite. In this population of patients, you have an effect of heart beating surgery reducing significantly the ischemia on the meiosis. We will return to this study after. And this other study proves that even it is not superior, it is not inferior to surgery with cross-clamping. So heart beating proved that it allows to preserve the left ventricular function in valvular surgery. On pump heart beating give good outcomes and give good advantages. It is more physiologic than cardioplegia. The next question is this technique safe? That's the most questioned asked by a surgeon when we talk about heart beating surgery. Is it safe? Is there any risk of embolization? The first study proved that the heart beating surgery is as safe as conventional surgery. There is no major risk, supplementary risk in heart beating surgery. This one shows that on fibrillating heart, and we are seeing later the different ways to get this beating heart, is not inferior in terms of safety to conventional surgery. Better than this, it seems that it is better. There is less risk in heart beating surgery to cross-clumping surgery. And this technique, when it is used by experiment surgeon, reduce risks for dysfunction and not augment the risk for stroke. This technique allows to make different operation: replacement, repair, and we are seeing the different technique we can use by this beating heart surgery. The first one, the classical controversy between on-pump and beating heart coronary surgery grafting. In this study, it's a meta-analysis from a team from China. They say that the beating heart surgery in this meta-analysis gave better results than classic surgery. But we said we have seen at the beginning of the slides that there are other publication saying the opposite. Here, I will ask you to see what is between the orange circle. It's a population of congenital. So VSD, ESD, pediatric population, beating heart surgery, given good results. So it isn't only in adult population you can use it. In coronary surgery you can use it. You can use it too in congenital heart surgery in pediatric population. And it gives the same results, not inferior to classic surgery. The same in mitral surgery, replacement, or even multiple valve surgery. On aortic position mitral position, tricuspid position, bivalvular, trivalvular position. There is some different techniques to have a beating heart surgery, perfused heart in all these techniques, and it gave a good results. What about surgery for mitral regurgitation with left ventricular dysfunction? That's the question of the presentation. At the first point, what is mitral regurgitation with left ventricular dysfunction? Left ventricular dysfunction with mitral regurgitation began when we have a fraction ejection of left ventricle lower than 60. So it isn't the same definition of low EF in other pathologies. The MR is different. In the second one, the graph, the guidelines of the European Society of Cardiology of 2021, you see the possibility, the therapies, possible therapies for MR. You have surgery and you have interventional techniques for severe MR. I want you to remind this for the rest of the presentation. It is very important to get that in mind. When you have different possible therapies, different possible techniques, it isn't the same position when you are in situation you have no other possibility except one. And it will be more complicated when it is an ischemic. And even in countries with financial support, with experiment surgeons, ICU, in this kind of pathology, the results are not so good. And in this situation, the use of intra-aortic balloon is very helpful. It have good results. Now, does heart beating surgery in left ventricular dysfunction get better? No. The study say that it gives the same results than conventional surgery with very low EF, very low left ventricular ejection fraction, below than 10. It gives the same that the conventional surgery with cardioplegia. So what's the advantage? We don't forget that these studies are all in Europe and United States. So there are in centers with possibilities of circulatory assistance, more possibilities, even transplant heart, which not exist in our countries, a lot of our countries in the continent. The approach will be then different. We began doing beating heart surgery because we have patients with low fraction ejection. We have no other possibility to get this patient to the OR. When we used the classic strategy, we have a lot of mortality. So 7 years ago, we began this technique in Oran with my friend Dr. Shiban Salim here. And we began with a simple technique. medium sternotomy, cannulation, classic cannulation, aortobicaval, snares on the chive, cardiopulmonary bypass on normothermia. When we want to open the left atrium, we put the patient in Trendelenburg position. We cross clamp the aorta temporarily. We open the left atrium. We put a vent into the mitral. We leave the clamp from the aorta, and we make our gest technique on the mitral, repair or replacement. There is some rules we have to respect to get a clear field. The most important one is to ask to the perfusionist and to the anesthesiologist to maintain a high mean pressure. Why? Because when the assistant exposes the mitral valve, he will create an aortic insufficiency, and your field will be submerged. You can't see anything. So you have to make sure that your aorta is in tension, so even when your assistant retract, there is no possibility to make an aortic insufficiency. Don't let your perfusionist and anesthesiologist have a pressure below than 70. The ideal pressure is between 70 and 80, no more than 80, no less than 70. And then you are working in a very clear field without bleeding. You are working very, very easy. You have the same condition to a classic intervention. When you want to close your left atrium, you have to be sure that your vent is into the mitral valve or into the prosthesis, mitral prosthesis if it is a replacement. To make sure that there is no embolization after the closure. Your vent will be efficacious. And the rest of the intervention is like the classical intervention. The second approach is by right thoracotomy. It's a little bit different. The access is very good. You have a best view to the mitral by the right thoracotomy than by sternotomy. I prefer always to get, when I can, to get a right thoracotomy. You are in front of your valve, your mitral valve. You see very well. You make sure that your lesions are very well seen, and your technique will be perfect. The difficulties in the de-airing, it will little bit more difficult by the right thoracotomy than by sternotomy. And you have to be sure that your technique of de-airing is very well done. Otherwise, you will have problems with stroke or neurocognitive problems in the ICU. I will present you our little series in the Center of Cardiac Surgery, which is in the east of Algeria. I was there from 2017 to 2019. I will present you this series. It isn't a big series. It's 18 patients. It represents 1.6% of the total patient we have done in this period, 1,123 patients. We began in 2017 with 4 patients. We, in the year after, 7 patients, and in the last year before COVID, 7th patient. Predominantly, they are male. Age, mean of the age 54 years, with limits from 36, the younger, to 69. And surprisingly, we have the same rate of ischemic and rheumatic. We are a country with always a high prevalence of rheumatic in patients, surgical patients, but we are in epidemiological transition, and we have etiologic, different, the etiology of Africa and the Western world together. That's make the problem more difficult to.
Your time is running out.
Okay, I will make it. That's the background of the patients. Quarter of patients are class 4. 2/3 are sinus rhythm. The left ventricular EF, 43% mean, 27 the lower. 6 patients with right ventricular dysfunction with the left ventricular dysfunction, and 9 patients had coronography. 4 patients only have lesions on the coronography. The surgery, 1/4 was emergent. 1 patient have repair. 1 patient have a replacement with bioprosthesis, and all the other patients have a replacement by a mechanical valve. The associated procedures, 1 patient have a CABG, and the other tricuspid annuloplasty or replacement. This is the cardiopulmonary bypass times. We have 3 patients dead in the early hospital mortality. It's 60% mortality. It's huge. The 3 patients are died in emergent surgery. There are the 3 in class 4 of the 2 are ischemic, 1 are rheumatic. We have late mortality 1 patient. It's the only patient we made a plasty repair 1 year after the repair. When you see the progression of the functional status, you see it is a good amelioration. All the patients go from 3, 4 to 1, 2 after 2 years of follow-up. For the EF, it's the same. All the patients have progressed evolution of the EF. It's slow, but it's always amelioration of the EF. There is no stroke or neurocognitive deficit in any patient. We summarize, we have heavy mortality in emergent surgery and especially acute ischemic mitral regurgitation. For the rest of the patients, clear progression in symptomatology at short and midterm, and slow progression of left ventricular systolic function at midterm. In conclusion, heart-beating surgery is an alternative in limited resources countries to give access to patients with critical situation, which in normal condition will need a circulatory support. This technique may be applicable for more common interventions in both adult and pediatric cardiac surgery. One thing to all our beloveds we have lose in this COVID pandemic. Thanks.
Thank you very much, Buzit, for your presentation. The time has been used up. We may not be able to take questions or interactions.
Okay.
Except we have time at the end, we'll proceed.
All right, thank you very much, Abdul Malik. Nice presentation. We move straight to the next presentation, which is going to be given by Habib Gamra from Tunisia. He's going to talk to us about mitral valve balloon dilatation.
I can't see my presentation on the screen. May I ask some help to get my presentation on the screen, please? Okay, thank you very much, Mr. Chairman. I would like to thank the organizer committee and particularly Professor Drisi Boumzebra for inviting me to this important meeting. I have the feeling that I'm only the only international cardiologist in the room, but this happens very often to our colleague surgeons when they attend our international cardiology meeting. So there is no problem, we are among friends. My task today is to give you an insight about a technique that you might know because it's been actually for many years. It's balloon mitral dilatation or balloon mitral valvuloplasty. I don't have any conflict of interest. Perhaps the only conflict of interest is that I'm an adult interventional cardiologist and not pediatric. But I will be giving you some insights on the application of balloon mitral valvuloplasty in pediatric and adolescent populations. Balloon mitral valvuloplasty, of course, is a therapy for mitral stenosis, and this disease is by no means a congenital heart disease. I mean, although there are cases of congenital mitral stenosis, but it's not the real issue in clinical practice. And the issue or the main or exclusively cause of mitral stenosis is rheumatic heart disease. That is, you have certainly discussed this in the last 2 days. It's a big problem in Africa, particularly. In 2018, there was a big event at WHO with the new data showing that there are nowadays more than 30 million patients with this disease. We are observing more than 3,000 a year deaths related to rheumatic heart disease. And unfortunately, the mortality rate for rheumatic heart disease has remained largely unchanged for the last 15 years. So there must be some concrete actions to change these figures. And in that year, in 2018, there was a resolution that was initiated by WHO asking very actively the member states to have a strategy to eradicate and eliminate rheumatic heart disease and rheumatic fever in the countries where it is present, and particularly in Africa. Now, how frequent is that? Mitral stenosis account for about 58% of all rheumatic valvular heart disease, whether it is pure or combined. Now, looking at the age, indeed, the pediatric population It's not the large population that is having rheumatic mitral stenosis. It accounts for less than 10%. And the mean average of age is around between 25 to about 50 years of age. Now, if we're talking today about balloon mitral valvuloplasty, that's thanks to the work of our colleagues, surgeons, who have already treated this therapy surgically. Because actually, for many years, surgery was the only therapy for mitral stenosis, with closed heart commissurectomy at the beginning and then open heart surgery. And in fact, there are three main dates, three main steps that have facilitated the use of a percutaneous approach to that. The first one is the Fogarty embolectomy catheter that was introduced in 1961, and that actually gave us the concept that actually we can place a balloon into cardiovascular system. The second date is, of course, closed mitral commissurectomy with Logan tubes, these two famous British cardiologists that have performed this procedure in 1962. And the other step, which is really important for this procedure, is the transseptal puncture that was actually invented by Ross in 1960. Now, in 1984, with the first report of balloon mitral valvuloplasty using a balloon by Kenji Inoue from Japan, and almost at the same time, there are, of course, this publication, the first publication by Kenji Inoue, who is a surgeon, by the way, and it was published in Journal of Thoracic Cardiovascular Surgery. 1 year later, a pediatric cardiologist by the name of Jim Locke has published 8 patients, pediatric and adult, in the New English Journal of Medicine in 1985. And in 1986, there was a publication by an interventional cardiologist from Saudi Arabia. His name is Muayyad El-Zaybag, who has used for the first time 2 balloons in the mitral valve. Now, after that publication, the reflex was to compare surgery to this new technique, which is a percutaneous approach. And this is a manuscript published in 1994 in New England, showing that up to 10 years, the results in terms of mitral valve area achievement was comparable between balloon mitral valvuloplasty and open heart surgery. In our place in Monastir in Tunisia in 1988, we have conducted a randomized trial comparing balloon mitral valvuloplasty, closed surgical commissurectomy, open surgical commissurectomy, and you can see here in black, that's the closed mitral commissurectomy. It was inferior to balloon and to open heart commissurectomy, open mitral commissurectomy, which was comparable to the achievement of balloon mitral valvuloplasty. Now, techniques after that first report by the Inoue balloon have been introduced, and you can see here 2 wires, 2 balloons, and then after that, there was the introduction of another technique, 1 wire, 2 balloons at the same time, and of course the Inoue balloon that has gained a wider acceptance because of its safety, because that technique does not have actually a wire into the LV, and there is much less risk of LV perforation. Now, just wanted to show you this. You might have seen this introduced by Alain Cribier. You know, Alain Cribier is very famous nowadays. He's the TAVI man. Alain Cribier, he has introduced a few years ago a metallic commissurectomy, very similar to the metallic commissurectomy used by our surgeon colleagues. It was introduced for the purpose of being able to resterilize, particularly in low resources countries. Unfortunately, it did not gain wide acceptance because it was I have used myself. It's quite bulky device, and then it was a little bit very quickly abandoned, at least in our region. I think it must be used maybe in some places in India. The balloon that is used nowadays is, again, the Inoue balloon. I don't go into the details, but it's very safe, but still very expensive. Now, to show you what this procedure is all about, just to go through a clinical case, this is a 60-year-old female, unfortunately adult, again, rheumatic valve disease known since 1994, recent symptoms worsening in the echo, assessment severe mitral stenosis with a mitral valve area of 1.2 square centimeter and a tricuspid stenosis in the same time with moderate aortic valve disease and severe pulmonary hypertension. This is the way we do it. So fluoro is absolutely mandatory. We make the transeptal puncture and we place that balloon. We inflate the distal part first, and then you pull back the balloon in order to place it at the level of the mitral valve, and you inflate it, of course, stepwise, going from one diameter to another with a monitoring by echo in order to avoid any worsening of a mitral valve, mitral valve insufficiency. It happens that the patient had the tricuspid stenosis, and the beauty of this technique, you can treat both valves in the same time with the same equipment, with the same balloon. And this is the tricuspid valve. This is a bad balloon positioning. You need to be careful to don't make any damage to the tricuspid valve, and then an optimal balloon dilatation, the waist on the balloon, and then the disappearance of that waist. With a good result in terms of mitral valve area. It went from 1.1 to 1.8 with no much worsening of the initial mitral regurg. Tricuspid gradient also has substantially decreased with a slight worsening of the tricuspid valve insufficiency. Now, in the literature, you will see many publications on the results of this technique and its achievement. Immediate results defined as a mitral valve area more than 1.5 square centimeter without significant MR is achieved nowadays in more than 90% of the cases with very low complication rate. The only complication actually that we cannot really control so far, although if you use the stepwise technique with the echo monitoring going from one size to another, you might decrease that risk. That risk of severe MR is about 3 to 5% depending on the series. Now, this is our experience on using this balloon in pregnant women, where actually the prognosis of mitral stenosis in these category of patients is bad in terms of morbidity and mortality for the mother and for the baby. We have one of the largest series about this particular setting. We have published our initial experience in neurointervention in 2006, about 61 pregnant women, mean age 28 years, mean of gestation 27 months, and the procedure was successful in all the patients but one who had a severe mitral regurgitation that required a consequent mitral valve replacement. Delivery was done at term at 38 weeks. Vaginally, and cesarean section was necessary only for obstetrical reasons in 3 patients, and there was no fetal suffering was observed in that patients. We have, after that, looked at the potential radiation side effects on the fetus, and that's by following the babies up to 20 years of age. This is the physical growth in terms of height and weight, and we compare them to the control group, and there was no difference between the two. And we did actually look at the IQ because we were looking for mental retardation related to radiation, and again, there was no difference between the control group and the babies, of course, whose mothers had the balloon during pregnancy. Now, at this stage, we're looking at the long term, 20 years and more, because this procedure has been introduced in our regions, I would say in the late 80s, early 90s. And up to 20 years of follow-up, the results are quite favorable. This is a series of French series by Boletti and Vahanian, published in Circulation. And up to 20 years, 25% of those patients would have the need of repeat dilatation. Looking at survival without surgery or the repeat balloon mitral valvuloplasty, approximately at 20 years, 35 to 40% would be free of those symptoms, a little bit less if you add as a criteria the functional class. Now, of course, after these results, we're trying to to find a score, to identify a score that can predict how would be the follow-up of these patients. And this is one of the scores by Bisha and Vahanian team, and that's based on age and final mitral valve area, valve anatomy and sex, rhythm and functional class, and the final mitral valve gradient. Basically, if you have a low score between 3 and 5, you can have a 50% freedom of events with a good functional results, which is quite favorable. Of course, these figures might be better because our population in Africa is younger with a more favorable anatomy and perhaps a better follow-up. Of course, it didn't work all the time like that, and one of the limitations is calcified valves, but still in that population, even in calcified valves, you will be able to obtain good result in about 2/3 of the patients, 75% in this series, in our experience, about 65%. Good result even in calcified valve. So calcification is not a contraindication to that procedure. Now, at follow-up, of course, you will have less good results if you compare that result in non-calcified valve. But still, even if there is stenosis, you can repeat the procedure. And this shows that actually repeating the procedure, you will be able to achieve good immediate result at about 94% of the cases. In this study, they did compare the results of balloon mitral valvuloplasty in patients with previous balloon mitral valvuloplasty or open commissurotomy or closed commissurotomy, and the results seem to be comparable, whatever was the previous commissurotomy. Now, I will finish my presentation by giving you some data about a series that we published in the European Heart Journal on juvenile rheumatic mitral stenosis, particularly and especially children and adolescents. The series has included, at the time, 654 patients, two groups, 110 less than 20 years, and 544 patients more than 20 years. The population characteristics very similar, but age, of course. But atrial fibrillation was more frequent in adult population, and that's obvious. And echo score was less, so more favorable anatomy in children. The results, we did consider not mitral valve area because of different the body surface area, so we did consider what we call indexed mitral valve area, and in fact, it was larger in the young population. So young population, we are able to achieve larger mitral valve area with very low complication rate, although almost none in the young population, only one systemic embolism, and zero mitral regurgitation, as opposed to the adult population where complications were encountered in more than 13% of the cases. Now, how about restenosis? Significantly less in the young population, 10.9% versus 15.3% at 10 years of follow-up. And you can see here, even at follow-up, mitral valve area or precisely indexed mitral valve area was larger in the young population with a very long follow-up up to 12 years. The conclusion of that manuscript was that balloon mitral valvuloplasty in children and adolescents is very effective and safe. Immediate results are better than in adult population, particularly with regard to acute complications. And although indexed mitral valve area was larger than in adults, freedom from stenosis and from clinical events at 10 years was not statistically significant between the two groups. Now, how about the guidelines? The American guidelines, don't look at this green part because this is obvious, of course. You have to send the patient to balloon mitral valvuloplasty if the patient has a mitral valve area less 1.5, symptomatic, with a pliable valve. But just look at this yellow and other indication, which indicates there are new niches for this procedure, even if the mitral valve area is not pliable. And this is even more clear in the most recent ESC guidelines, where actually balloon mitral valvuloplasty can be suggested in patients with suboptimal anatomy if there is an indication and high risk of surgery, and in patients with high thrombolic risk or prior to non-cardiac surgery, for example. So in conclusion, Mr. Chairman, ladies and gentlemen, mitral stenosis remains a public health problem in many developing countries, particularly in sub-Saharan Africa and South and Central Asia. Balloon mitral valvuloplasty has become the therapy of choice in patients with mitral stenosis. It is a very safe procedure in inexperienced hands, even in unusual settings such as pregnancy. Long-term outcome is very satisfactory, particularly in patients with favorable anatomy and good immediate result. Scores for patient selection and long-term outcome prediction are very useful and need more refinement. Current data support broad use of balloon mitral valvuloplasty even in patients with impaired valve anatomy but who have favorable clinical characteristics. Thank you very much, and I invite you to this meeting that will take place in Morocco in October, jointly with the Congress of the Moroccan Society of Cardiology. It's called the Pan-African Course on Interventional Cardiology, Wspchs 2022. So we welcome you to attend in that meeting. Thank you.
All right, thank you very much. I think time is fast spent. We are running behind schedule. We will end this session at this point. The other presenters that were unable to ask and discuss, I think the discussion can continue while we're taking our tea break. We will resume by 11:15 for the next session. Thank you very much.
of the World Society, the development of the educational tool, the World University. This will be followed by the outgoing presidential address by our outgoing president, Dr. Zohair Al-Haliz. And the third and final component of the session will be the 7th Aldo Castaneda Lecture, which will be presented by Dr. Giovanni Stelline from Padova, Italy. So perhaps we'll get underway with our first session, first component of this session, the World University for Pediatric and Congenital Heart Surgery, a global educational tool. And this will be opened by Dr. Cherenkov. Thanks, Krista.
Thank you, Richard, Marcelo, ladies and gentlemen. So the idea of an education tool online actually came quite a few years before the pandemic. It's an idea I've had for many, many years, but every time I would mention it to colleagues, well, that's another idea, one of Crystal's ideas, and well, there was no traction whatsoever, so I kind of abandoned it. But the pandemic came, and we set up a Zoom call. There were 39 or 40 people on the Zoom call, and this is just a picture that you can see of who was at that session. This was on May 9th, 2020. And suddenly, this idea that looked very far-fetched became extremely relevant to the times because of the COVID, really preventing face-to-face meetings for 2 years. And you can see a lot of the notables. I don't know if we can enlarge the slide to make it full screen, but a lot of the notables, we can see our president, Zohair Al-Haliz, Marcello Giattini, a lot of people, important people, were part of that call, and there was a kind of a no-brainer. Everybody felt that this was an excellent idea, and we should set it up, organize a sort of a council to debate of how we're going to deliver this educational tool and how we're going to organize it. So we had what we call a bit of a constitutional council of the World University, and the first sort of points was to decide on a vision and a mission of the World University. So I'll very quickly read it. The vision of the World University Pediatric Congenital Heart Surgery is that every healthcare professional anywhere in the world involved in the care of patients with pediatric congenital heart disease should have access to ongoing education. And the mission is to promote and facilitate access to education of surgeons and allied professionals involved in the care of patients with pediatric congenital heart disease, kind of mirroring a little bit the mission of the World Society. And we worked with Claudia and a few others on a logo, creating a logo. Sometimes these symbols that convey a message, which with time becomes quite important. And so this was our logo, and you can see the sort of, I apologize. I'm going forward. No, I gotta go back here. Sorry. So it's translated. We also have a motto, which is translated in the 6 official languages of the United Nations. And I spent weekends looking at mottos of multiple universities all over the world. Spent a lot of time looking at something that is appropriate and something that has not been used to my knowledge, by anybody else. So we came up with the idea of Scientia undique e universa, which really means knowledge everywhere and for all. Now, a number of representatives, important leaders of the various continental organizations participated in this process of establishing the World University, and these organizations are listed here. We decided to do a questionnaire and find out from our membership whether this was a good idea or maybe they wouldn't be interested. And we had really responders from all continents. It's very nicely balanced. You can see the breakdown. and 95% felt this was an excellent idea that should be pursued. And some of the points was what kind of a format should this online education take place? And you can see almost anything that we do was desired. A series of webinars, videos, pictures, library, case presentations, discussion with experts, regional educational needs, special areas, and controversies. So these are all things that it's impossible to put together in one day or 1 month or 1 year. So we started with a series of webinars. Also the topics of interest. There's a tremendous thirst for almost everything. They felt that the topics of congenital heart surgery 100% important, cardiology, intensive care, education, congenital heart surgery, advanced topics, anesthesia, perfusion. You can see the percentages. I mean, it's almost 100%. So we set up a constitutional council to work out a bit the constitution of the World University. We set up a curriculum committee. Each webinar, and they come up once a month, is co-chaired by 3 chairs from, the rule is 3 different continents. And we have a program committee for every webinar that, depending on the webinar, could be anywhere from 9 to 17 people participating in the elaboration of the program for each webinar. We set up a leadership. I'd just like to thank some of the leaders from the various organizations: Frank Edwin, Drissi Zebra, Darshan Reddy, Susan Voslu, Adel Elgamal, and from our Asian friends, Kisaburo Sakamoto, Hatil Abdulgani, Zohair Al-Khalis, etc. CHSS, Joe Derani, Jim Tweddle, Emil Basha participated, Carl Bakr, Jim Kirkland, EXA, George Saris, Joseph Fragata, Bogdan Marushevsky, Martin Halvan, Claudia Herbst, Serta Cicek, Sociedad Latina, Nestor, Pedro Becker, Jorge Cervantes, Marcelo Jattini, Beatriz Forlaneto, Ivan Nino de Guzman, Erika Perez Albrecht. All these people participated. And of course, the leadership of the World Society, at the time President Marcelo Jattini, and then our current President Zohair, Jim Kirkland, Richard Jonas, and all the notables. We set up a curriculum committee with co-chairs from each continent that are listed here. And for Africa, Frank Edwin is the co-chair, continental co-chair for Africa. And we set up a 3-way leadership, at least for now. Jim Kirkland is the academic leader of the World University. Claudia is our Secretary General. And I sort of deal with administrative activities. And we'd like to acknowledge the financial support of the Montreal Children's Hospital Foundation, because everything we do, you might think that it's for free. Yes, it's for free for people, but everything has a cost. You have to pay the bills. So there's some financial issues that not insignificant. I think I'll stop here, and then we can move up to the next presentation.
So thanks, Christian, for the introduction of the World University. Dear ladies and gentlemen, dear chairman, it's an honor for me. Give me a second, please. It's an honor for me, coming up, to show you what we have done in our first and second academic year, starting in 2020 until today. What we have reached so far: 18 webinars, 45 hours of content, 12,247 registrations, and 14,868 hours of learning. In our first academic year, we had the following topics for webinars: transposition of the great arteries. We had the trilogy of Fallow. We had coarctation of the aorta, hypoplastic aortic arch, interrupted aortic arch. We had 2 webinars on AVSD. We had a webinar chaired by our collaboration society, the African Society on Rheumatic Heart Disease. We had what kind of topics we had? We then started the second academic year, and there we had hypoplastic left heart syndrome, basics and complex issues. We had a topic on the hypoplastic left ventricles and indications for biventricular repair. And we had diseases of the aorta, aneurysmal disease. So in total, we had 18 webinars over those 2 years. We had 42 chairs from different continents, and we had a faculty of more than 100 people from all over the world. So from the more than 12,000 registrations, let's take a look at the webinars. We had almost 1,000 registrations for the HLHS basic webinar. The range was between 500 and 1,000. And I want you please to remember TGA, our first inaugural webinar, which had 600 registrations. I'll come back to that later. So, and how about the live attendance? So you have 2 opportunities if you register for a webinar. You can attend it live, which brings you the opportunity to interact with the speakers, to ask questions. And if you participate more than 60% of the webinar, you get a certificate. Or if you don't make it in time, no problem. You can watch the recorded version. And here you can see that in almost every webinar, more than 50% attended the webinars live. Here are the top 5 webinars on registration and attendance. On top was HLHS, the basics, AVSD basics, LVOT outflow tract obstruction, on valve aortic stenosis, then the biventricular repair of the hypoplastic left ventricle, and the trilogy of Fallow basics. And you can see here on the numbers, there have been more than 800 registrations for each of them. Top 5 attendance, this means live attendance, was on top the AVSD basics. Again, hypoplastic left ventricle and its role for biventricular repair. Then we had the total anomalous pulmonary venous connection, global perspectives and treatment. Left ventricular outflow tract obstructions, valve aortic stenosis, and again, hypoplastic left heart syndrome, the basics. Let's take a look at the recorded webinars, how you can find them. You can find them on our website, wupchs.education. Our website is the platform for interacting with the World University. Here's a screenshot. We have a World University library. And if you go to the library, you can find first the recorded webinar. By a click, you are in. And second, a webinar reference library. For each webinar, we support a library which mentions the most important 3 papers referenced in the talk. And these recorded webinars had 8,156 views over the period of the last 12 months. But that's not all. Here you can see the recorded webinars, again by topic. And I asked you to remember the count of DGA. Do you remember? It was 600 registrations. So the recorded webinars were watched by more than 300, about 355. And let's take a look at this. Because there were more than 700 people watching the recorded version of the DGA, of our inaugural webinar. So how comes? You can bypass our website and via a link or by a recommendation from a colleague, you can watch the webinars on YouTube, and the bar you see, the orange one, is the YouTube click. So the amount of watching the webinars is still mounting. Next, I want to show you how the certificate looks like. This is just an example. We have two types of certificates. One is a certificate of attendance, and the other one is a CME accredited certificate from the University Alabama Birmingham. And here are two examples. You can get a single certificate for attending one webinar, or you can get a cumulative certificate if you have attended more than one webinar. So next, we were interested in who is our audience and how can we best support them. So we asked them in questionnaires after each webinar. First of all, what is your age? And you can see here, and we had this topic this week, we discussed it already, because you can see here, we have a little bit of lack of young people between 20 and 29. So we already made decisions on doing a fundamental series to get them on board and to cover their interests. But on the other hand, you can see that the spectrum of ages is well balanced between 30 and over 60. So where does our audience come from? Our audience come from all over the world, from 126 countries. And again, we checked for the website. We had 5,110 users with more than 27,732 events on the website over the last 12 months. So who are the top 10 website users? On top is the United States, followed by Saudi Arabia, Poland, India, Canada, Mexico, Ukraine, Argentina, Brazil, and United Kingdom. And I would have loved to list all 126 countries, because every country interacting with us is so important. For the sake of time and for the size of the slides, I couldn't do it. So let's take a look at this. Again, the website users. In our first academic year, if you compare the first to the second academic year, we had an increase of 255% in regard to events on the website and to website users. So as I told you, the website is the part of interacting with the World University. It's the part of watching the webinars, watching the reference library, taking a look at the journal watch and everything we offer. So we had an increase of about 255% in regard to events and users between both years. Okay, next, we wanted to know, how did we do? Are we going on the right path, or is there something we should change or adapt? So overall, the participants rated the event and in the majority as excellent. but we wanted to go a step further. You can say, yeah, it was excellent. But if you really be honest and you want to know, how did we do? You ask the people, would you recommend the World University to a colleague? So as you can see here, for every single webinar we gave, people would 100%, almost 100%, recommend the World University webinars to their colleagues. Next, I will show you an example for an analysis of, here are not all webinars listed for sake of size, but it gives a good overview for the question, what percentage of information was new to you? And you see the percentage of new information was achieved in 25 to 75% of participants. When do you expect to use the information from this webinar? And as well, you can see more than 70% will use the information of a webinar, expect to use it in the next 2 to 6 months. I want to thank the committee of the Journal Watch under the leadership of Jim St. Louis for their effort, for the time they're bringing up to implement and to hold it ongoing to support our community with up-to-date and interesting articles with comments to it. And I want to thank the contributors which send us suggestions on interesting articles from 7 journals which cover the topic on congenital heart surgery. And over the last 12 months, the Journal Watch had 913 views. And at the end of my speech, you may be interested, what is upcoming? What's coming next? Okay, for sure, we're going on with webinars. We will support you with monthly outstanding webinars, outstanding speakers. Upcoming is the 19th on diseases of the aorta 2, miscellaneous conditions in July, and the 20th on congenital mitral valve disease, global best perspectives on treatment in August. But more of that. We will go on to extend our webinar library. We will go on to extend the reference library. We are up to build a picture library for you, where you can use pictures. We are already talking about a fundamental series to get young people on board. And there is the idea of a mentorship program to connect people and many more. So the World University is for you. So let us know what you need, what you're interested in, how we can support your education. And if you're interested to come on board, to work with us, to support us. Thank you for being a part of the World University.
One, 2 down. No, next. Yep. No, yes. Well, thank you very much. So Claudia and Christo have given you a nice background and current status of the World University. So what about the future? So first, I want to really acknowledge the tremendous amount of time that Christo Trevenkov has put into the World University. It's been really the heart and soul of Christo, which has really propelled this forward. And Claudia has made massive contributions in time, energy, and intellectual input. So thank you, Claudia. But most of all, thank you to all of the moderators and presenters in those webinars, which have been incredibly impactful. I mean, the level of expertise, for those of you who might not have witnessed any of the webinars, is really incredible. It's world-class. It's expert people, as you'll find in the world, about these various topics. And so what can we do to build upon this success? And I want to make some serious comments, not just aspirational, about what we can expect. So this is a snapshot, maybe a few days prior to what Claudia presented, but you see really the massive impact in the number of successful webinars starting from nothing, and the number of learning hours and registrants. So I think that given the amazing progress that has been made in 2 years, what could we realistically expect over a 5-year plan? So I think the options for a portfolio would include not only webinars, but a video library, journal watch, formal surgical education, a certification process, a platform for opinions and advice, and a mentoring. So I'll make a few comments about each that I think are realistic. So webinars. So these are certainly the hallmark of the World University. We will likely remain on a monthly cycle. The program committee will certainly review and refine the topics, largely driven by participant surveys. One of our important objectives is to increase the participation of our partnering societies, with the goal of joint educational programs at least once every 6 months with one of our partners, so that they would do the planning, the selection of topics, and so on. The video library. So we've had some preliminary discussions about a video library. We think this is extremely important. There would be the need to identify a director of the video library effort. So we'll be looking among you to see who might be interested in championing that. There will be a solicitation process for videos, and specific operations will be highlighted. These don't necessarily need to be world-class videos, but useful and meaningful videos that can help young and mid-level surgeons understand the nuances of specific operations. And I can see that in our annual or biannual meetings that there would be a contest of videos, those that are most watched and those that would be most impactful, judged by a committee of experts. Also, following the pattern of certain other societies, we would highlight video sessions among those videos that were contributed to the World University. The Journal Watch needs to be expanded, and Dr. St. Louis has done a masterful job of getting this started, but we need to expand the process. This will be an important source of a formal curriculum in congenital heart surgery learning that needs to be expanded and made a very important feature of the World University. And this leads me to what I think is a really important direction of the World University, and that is some sort of formal educational curriculum and certification process. By that I mean testing, evaluating the knowledge of those who are interested in documenting their knowledge gained through the university. So proficiency testing of the material in the webinars based on questions supplied by expert presenters. This formal certification process would be likely based on not only the webinars, but also the Journal Watch, as well as the film library. And likely it would be based on a quarterly assessment of what was offered that quarter. This would then generate a certificate of learning, not surgical technical expertise, but knowledge about the field of congenital heart surgery, which we hope then would lead to greater interest in going back and viewing old webinars in the library of the World University, looking at the videos, and also joining in on the Journal Watch. And I can see that this could be an important step toward a global process of assessing the knowledge of congenital heart surgeons from one country to another that would be helpful in the overall globalization process. We also need to have a platform for exchange of opinion and seeking advice. Now, there are other societies which have used the platform of Basecamp, which is a platform which is available. There is a small charge for the use of Basecamp. It is a highly successful platform in which there is no personal health information shared, but there is a platform for free exchange of questions, ideas, opinions among surgeons or students. Also, there can be a separate portal for patients and families so that they could become involved in the process. And we would plan to set this up within the next 24 months. And finally, mentoring opportunities. So the World University needs to be a platform for facilitating the globalization of shared knowledge and practice of congenital heart surgery. Obviously, the goal is the mission of the World University, which is to facilitate the knowledge of congenital heart surgeons globally for the purpose of improving patient care. And so we would envision using the World University as the architectural platform for mentoring in an informal way, partially through the Basecamp mechanism, but also if we can get some degree of funding, there would be a process for having traveling fellowships or even less formal but equally important virtual relationships between surgical mentors and mentees from various parts of the world. So I think these are very realistic goals over the next 5 years. We can probably expand to other areas as well, but these we fully expect to be implemented. And with a little bit of good luck and engagement of all of our partners, I think we have the opportunity to make the World University really a leader, not in surgical training, but in pediatric congenital cardiac surgery learning. So thank you very much, and I hope that all of you will get involved.
Thank you, Jim, Claudia, Christo. Well, we have some time now for discussion, and I hope that all of you will take this opportunity to contribute your ideas and questions about how the World University might best help you. And perhaps while you come to the microphone, I could begin by asking Jim or Christo or Claudia, how exactly, what would the specifics be of a mentoring program in which individuals, a small group, for example, 10 or 20 individuals, might have, say, a 1-hour discussion session with a specific mentor? How exactly could that be set up? Would that be an opportunity for perhaps a sort of closed book assessment of individuals? I mean, you have the open book assessment, the standard CME type assessment where you watch a webinar and then you can go back to answer the 5 questions at the end. So essentially, you don't have to have learned anything. You can just go back and find the answer. But if it's a back and forth with a mentor, then it's an opportunity for learning, but it's also an opportunity for assessment and certification. So the mentor could fundamentally give you a certification at the end of that process. So is this sort of thing feasible? How would we go about actually setting that up? Is that something people would be interested in?
Thank you, Richard, for this excellent question. So the idea is still building up, but I give you some insights in our thoughts. So every academic year starting with a meeting of a mentor and his mentees with a session. This session could be about anything they want to talk, about an input talk from the mentor and a connecting meeting, learning about the needs of the mentees. And then over the whole year, they support and go with their mentees via email contacts, via Zoom meetings, whatever needed, phone calls, maybe let's stream visits at the center. Either way, this all would be possible, and this could happen in a way that's needed. More contact or less contact, whatever. So if I'm a mentee and I know, okay, I have a complex case, I don't know how to handle, I can ask my mentor over the year. This is the surgical part. But there's another part. It's about research. It's about publication. Mentors can support their mentees in such things. They can proofread, guide them, teach them basics, something like that. It's a very individual program to connect people. And at the end of the year, they meet again for a session to conclude, to see what happened, what was fine, what went wrong. The feedback is really good for us. We need to go on to the next year. And of course, the light would be that there could be a certificate from the mentor when they meet each other, when they get to operate together. There could as well be a certificate. It's possible.
Can I just add a few short comments? Rome wasn't built in one day. So these are great ideas, but unless they become a reality, they just remain ideas. The way we went in a very prospective way to take the idea of an online educational tool, which is the World University, required multiple Zoom calls, meetings, debates, planning. I think with respect to the mentorship program, it's a fantastic idea, but remains to be defined. Richard, you're raising very good points about it, but none of these things are really defined right now. I think we need to set up a committee, a mentorship committee with input from all parts of the world and interested individuals, and to come up with a plan, concrete plan, start with more basic things and build upon that, build upon the success that we might achieve. But that's going to be a long-term process. But once we lay a strong foundation, then there's a much greater chance of participation, building on it, and long-term sustainability. So I would invite anyone in this audience to get involved with your ideas. Once you have your idea in, then you have to be responsible for making sure it happens with our help, because the 3 of us cannot do it all. Neither can do it the 10 or 15, 20 member curriculum committee. So we need a separate sort of a bit of an administrative structure to take on this mentorship program.
Working here. Okay. Hello, Ignacio Juanera from Argentina. I want to congratulate, of course, all the society for this fantastic meeting. I'm very enjoying this presentation, great presentation. I want to share my thoughts regarding what Claudia showed in one picture and what Marcelo Jaten commented, I think yesterday or the day before in the governing council meeting, regarding the involvement of the young people in our university and of course in our society perhaps. For example, for the last 2 years in our city in Cordoba, in our hospital, which is a university hospital, we created a curricula that is an optional curricula for congenital heart surgery, congenital heart disease for medical school students. It's an elective 1 month curricula that is given optional for these students. When I was in medical school, congenital heart surgery and congenital heart defect is not a strong subject given. So what I'm thinking about is how can we do to include these people and perhaps improve what Claudia showed in the picture, that the lesser proportion of people engaged in the university is, of course, in the World University curricula, is the people between 20 and 28, I guess, they show. So that's share my thoughts and perhaps work on what Marcelo commented the other days. Thank you.
You know, if I could comment on that, I do think it's very important to recognize that it's not just surgeons that we need to teach. We also need to educate the intensivists, the cardiologists, the whole team that is involved in managing a child with congenital heart disease. And if I can give you an example, I mean, I've been doing this informally with a surgical team in Shenzhen, China, and the way we do it is I send a PowerPoint presentation ahead of time, which is translated into Chinese so that we have simultaneous projection. I've really learned to do a share screen running 2 simultaneous PowerPoint presentations. So side by side, English PowerPoint and Mandarin PowerPoint. And that way, many of the staff who may not be fluent in English can look at the Mandarin slides. And at the end of the presentation, the discussion tends to be predominantly with the surgeons, though it's also set up so that the fellows are required to ask questions of the presenter. So there's an interaction. So maybe 5 or 6 fellows will have 2 or 3 prepared questions each. And then the senior surgeons will have a more extensive discussion. But that sort of mentoring, I think, can be really helpful for the entire team. And you raise a really important point that we need to focus on education of the whole team.
If I can add something. Of course, there are many ways of doing this. There are different initiatives from all the teams around the world. What I think it should be interesting is some global leadership, and maybe the World University could do this. And of course, it's not, as Christo always says, it's not a work that could be done in days or weeks. It's a hard job. It requires discussion, requires a lot of things. But I think that it's important to engage the young people. Of course, it's very difficult for a young guy to know is in the medical school in the 2nd, 3rd, or 4th year that he worked with congenital heart surgery. It's not easy to have the decision so early, but if we have ways to bring them all together, I think it should be an interesting issue to look for. And the World University can lead these processes. Of course, not immediately, we might discuss, but it should be an option as many of the options that we have, as just Richard just described. Please.
My name is Innocent from Ghana. I feel that sometimes the webinars are very long. So you realize that when you look at the participants right from the beginning, by the time you are ending 3 hours, sometimes 3 hours plus, the number goes down. So if we could kindly reduce the hours to say 2 hours, I think it would be quite good. Thank you.
Thank you, Innocent, but I'd just like to clarify the webinars are never 3.5 hours. They're 2.5 hours, and almost always we finish on time or within 5-10 minutes. So, and also when we send the original questionnaire, what kind of length people would prefer. The ideal was about an hour and a half to 2 hours, but after every webinar, we have a question about the length of time, and the overwhelming majority said it's just right. It's just the right time. We tend to explore the topic quite in depth. We have between 8 and 9 international speakers from all over the world. And I agree with you. It's hard to put the time investment, but people are used to it now, and the majority feel that the time is appropriate.
Okay, thank you.
And if I could add, I mean, it's important to remember, as Claudia's pointed out and others, that this webinar is available online for you to look at any time. So if you have to run off and answer a page, then you can do so and then come back and look at the recorded webinars. But it seems like the recorded versions are being a little underutilized. And so if the time length is too long for you personally, you should take advantage of the fact that it's available online. Yes.
So my comment and recommendation would be to talk to some of the NGOs who have been doing a lot of mentoring work over the years. And David Overman and Jim St. Louis have worked with Children's Heartland for many years, and so they know and have experience with mentoring, especially during the pandemic. I think we had to switch all of our work online. So that's one comment, and the next one is a question. A lot of the low and middle income countries don't have congenital heart surgery training programs. And so this would be, I think, a great opportunity for the society to think creatively. Can you help them develop those? Siva, I don't think he's here, but for example, Malaysia recently got into a partnership with a society in, I believe, Scotland to develop the curriculum and to implement their cardiovascular surgical training program. And they haven't even gotten to congenital yet. But there are examples around the world, and so the society can definitely play that role of developing the curriculum, assessor of the trainees potentially, and kind of build that capacity locally. And that's definitely a time-bound project. It's not something that the society would commit for many years to come.
Thank you. Yes. Is it Miriam or Yasmin?
Miriam.
Boumzibra.
Yes.
Dr.
Hello, everyone.
Boumzibra's daughter.
So I'm Miriam Boumzibra. I'm a Moroccan medical student studying in Belgium. And since you were asking about medical students' input, I wanted to give my opinion about this. So as for the word university, I think it's a very good idea. And to implement medical students, maybe we can think about physiopathological content made easier for student level, and maybe we can also be offered research opportunities. As yesterday during the lunch session you were discussing about the word medical for database, and that sometimes you had issues because of the institutional resources. So maybe students could help, because we students are always keen to grab a research opportunity, and we're always very excited to help. There's also Marrakesh medical students over here, and we're all very honored for this opportunity. And we also work with an International Federation of Medical Students Association that is recognized from the World Health Organizations, and they have a research committee, so we can work also on this project. So thank you.
It's a wonderful
Thank you.
suggestion. Thank you very much. And thank you for your wonderful work, for you and all of the medical students who have done so much wonderful hard work in making this conference such a success. But yeah, thank you. It's a great opportunity for medical students to become involved.
Yes, indeed. Thank you.
Yes.
Okay. My name is Acrisio Valente from Brazil. I want to congratulate the society for this effort and success in bringing knowledge in congenital heart disease all around the world. I think that the World University is doing a very good job. I enjoyed very much the suggestion of Dr. Jonas, and I have one more suggestion. If it's not possible to the society offer opportunity to visitors to go to some hospitals, stay short periods of time, not just for young surgeons, but middle-aged surgeons like me, and in an official way, I don't know, you can offer in the sites some senior surgeons, big names of the heart surgeon, can offer short periods of 3-4 a week to visitors to go there, to take some routines, to observe some surgeries. I think it would be perfect. That's my suggestion.
Thank you.
It's an excellent idea. Obviously, it takes time, resources, and also knowing who is interested. Just to give you an example, at every meeting, people somehow meet behind the scenes that we're not even aware of this cross-fertilization taking place. As an example, the surgeon from Mauritania came to me and wanted to go for a month somewhere in an English-speaking center so he can watch surgery, but also improve his English language. And we sort of talked about possible sites. And then I said, well, maybe Liverpool, UK with Attilio Lotto. So I talked to Attilio, they got together, and I think there's a plan for a month visit of our friend from Mauritania to spend in UK. So that's an example of an on-the-spot sort of spontaneous kind of mentorship setup.
Again, this is being done. I think for most of us here, this is being happening. Maybe what Acrisio said, you are not so old, you are a very young surgeon. And what Acrisio said is to maybe to have some official position of the centers that could receive the young surgeons and could be mentoring some of them in a different way. So I think it's another point to be discussed.
Well, that's definitely a potential role for the World Society and the World University. So we have to collect the information, which centers are willing to provide this mentorship and who else is interested. So it's kind of we can be kind of a triage area where we are matching people, but we cannot provide resources for travel and financial expenses. That's not in our possibility, but we definitely should get into a program of mentorship and matching people to their needs.
Next question.
Yeah, thank you so much. I actually, it's a regular part of this university, and I follow it, and I recommend it to our fellows. I remember there was a discussion back in Barcelona some 3-4 years ago, how it is difficult for international fellows to be trained in the best centers in the world. The only possible place for really these days for international fellows, especially from developing countries, to be accepted visa-wise also, being board certified is becoming very difficult. So I know you have a 5-year plan of making this sort of a learning opportunity for surgeons, but is there any way that you can do this? It's a university, as the name indicates. Is there any possible way your World University making a curriculum and certifying surgeons? Obviously, that should involve some sort of actual work being done. For example, it could be mentors taking up surgeons. You've just brushed it off, but is there any way that you can give a certificate for a young surgeon to come back home? Just not, it wouldn't just be an experience for him. It would be something supported by paper, and then he'd be back to his home country and be able to work. Finding training, legitimate training that is accepted in their home country's board is becoming a very difficult issue. That's something that it can step your university up to.
Well, that's a very good point. And the problem of mobility of surgeons being restricted by various certification requirements in different countries has been a focus of the Global Council for Education in Congenital Heart Surgery, and it's certainly something that we are working on. It is nevertheless going to be a requirement that if you want to work clinically in another country, at a minimum, you have to satisfy the requirements for getting a medical license. There are not many countries, there are some, but certainly the United States has very strict requirements in terms of getting a basic medical license. You don't have to have any proven certification in surgery or heart surgery, but you do have to prove that you're a safe doctor before you will be allowed to assist in actually caring for patients in the United States. So, I mean, certainly I trained in Australia and yet I ended up working in the United States. But as soon as I finished medical school, essentially in the same month, I went and did the certifying exams for the United States because I knew at some point I might want to work in the United States. So I do think that's a planning issue. And if you look at my textbook, the second edition of my textbook, Comprehensive Surgical Management of Congenital Heart Disease, it outlines all of the steps that are required for medical certification, for getting a visa, for getting hospital privileges. There are multiple steps, some of them national, like your visa, some of them state-based in the United States, like getting a medical license, and some of them hospital-based. So there's many bureaucratic steps. And I don't think there's going to ever be any easy process in most countries for coming in and working clinically. Claudia outlined very nicely how you can get a knowledge base for learning about congenital heart disease. And that is a role a World University can fulfill. But actual hands-on patient care is going to require a medical license almost anywhere you go. David Overman.
Yeah, I think that is another level of, certification and qualification, et cetera, that probably is not appropriate for the World University to try to bite off. But I think what you're hearing is maybe, a thirst for simple exposure, observerships, this kind of thing. And I know within the US, NPC-QIC is now involved in a program that identifies both candidates for such participation and volunteer institutions. And there's a kind of an application process and a qualification process. So it's just a quick comment to say you could talk to Adil Hussain, who's kind of the leader on that for NPC-QIC, and you may have some good kind of guideposts and advice about how to roll that out. I think it would be a very important addition to the mentoring aspect of World University, though, is to have a roster of institutions who are open to and willing to do that, and then some sort of formalized application process. The other key thing is that the applicant needs to identify funding for their experience ahead of time, or you can't qualify. So.
Thanks, David. And I think it's fair to say that essentially every institution, certainly in the United States, and I would imagine globally, all you have to do is write to the chief of the program and say, I would like to spend 1 week at your program observing surgery. I know that in Boston, I essentially never did an operation where I didn't have at least 1, 2, or 3 observers from countries all around the world. And I know that's true for most of the surgeons in major institutions. So don't be shy about just contacting the institution and saying, I would like to spend time there. And to get funding, what many people do is get funding to go to a national meeting like the AATS, and then at the same time, on the same trip, to visit the hospitals that are either in the city of the conference or some nearby city. So there's actually being a surgical observer for a week or two is available anywhere, anytime.
Thank you, Teddy Lotte from Liverpool. I don't need actually to reiterate how good is the concept of the World University. I have been part of it and I've been learning a lot. So it's unbelievable how this has been achieved in only 2 years. I have two comments. The first actually is that I come from a country, Italy, where education is not a privilege, it's a right. And I think actually the ethos of the university has to be that. So everyone around the world needs to have access to education. And this is actually highly specialized education that require high educated people to educate others. And then it brings the second comment, which is the role of the educator that is in my mind. And I view it like the father that want to spare their children the struggles that they had to. So if I have to remember when I first landed on my list as a first appointed consultant, I completed VSD, and I thought, God, tomorrow I got this to do. And I'm shaking now actually thinking back of those days. And I had two things to look at. I had Dr. Jonas' textbook and being in the UK, the Stark Delaval textbook. And YouTube was not really available. But the key actually that now we have technology and there is no reason why we should use technology to spare the young guys the struggle and those hours of thinking in the night, how I'm going to repair that complete VSD if the valve is not repaired well. And I really would like to pass that message actually, because there is a technology there. And there is the possibility to be in theater with a webcam and you can actually show what you're doing to someone else on the other side of the world and see actually and take them through that. And it could be the other way around. They can be in theater and the mentor can be on the other side. And it's just to give their reassurance that most of us probably when we started didn't have. But somehow we stumbled through these kind of problems. And now we are here talking about how good we are. But at the beginning actually was a fear for everyone. Thank you.
Thank you.
Attilio, I think you will be chosen as a video director of the World University.
Marcelo Jatin will now give us the introduction for the presidential address by Dr. Zahir Al-Khalif. Thank you, Marcelo.
I want to thank you, the World Society, for the invitation to this very nice job to introduce a friend and the outcoming president of the World Society. And I want to thank Drissi for all the hospitality and for the success of the meeting. It's very easy to introduce Zohair. He doesn't need any kind of introduction. He's a very well-known person. But I think there are some points that must be touched during the presentation. I took part of the history of the World Society since the beginning. I was in the 2004 joint meeting of the first joint meeting of the Congenital Heart Surgeon Society and the EXA in Montreal, where this subject came on mind. And then again on 2005 in Buenos Aires during the 4th World Congress of Pediatric Cardiology and Cardiac Surgery. And finally, I was present at the 2006 AATS meeting in Philadelphia, where the society was officially founded with when the definition of the bylaws, the logo, the name, the meetings, the people who will take part. This was 2006. Since that, This is a slide I present in my presidential address in Orlando. The World Society is growing. It's reaching steps and steps. And at that time, there was but there was the meetings, there was the World Journal, which was a reality. The database was initiating, and there was some requirements for research and training. And what we have now is that the World University is a reality after 2 years, and we might discuss and continue discussing mentoring, training, education, certification, and all the thoughts and all the steps. So it's a big pleasure to be together with a lot of very, very dear friends, and that includes Zohair, that was involved since the beginning. There are some thoughts and reflections. What are the requirements to become a president? You must understand the community needs. You must have sensitivity to help the basic and then the more complex demands. You must work and understand the different environments, must improve the quality of life of the target community you are leading with. Of course, it's never unanimous, and there will always be big responsibilities and big expectations. Considering the world representation of the world society, we might consider that we are different. We are different in education, information, social and economical conditions. We are different in structure and political basis. There are different demands, sometimes populisms in some of the countries, and political interference and corruption. We are having the opportunity to discuss a lot this during this meeting in Africa, and Frank, in his presentation yesterday, in his presidential address, touched on some of these points and how we could help everybody and how the society could help to put everything together, finding the best solution. The first time I met Zohair was in the Brazilian Congress of Pediatric Cardiology and Pediatric Cardiac Surgery, which was in São Paulo in 2006. And I was impressed by his presentations. There were huge numbers, in special of the Ross operations, and I had the opportunity to meet Zohair there. Since that, many meetings, many opportunities, many times. This picture is it's a very interesting picture because at that time Hiromi was the president, during the meeting in São Paulo, and Richard was the first vice president, I was the second, and Zohair became the next second president, and the time's passing. And I had the opportunity also to meet very good friends there and receive them in my house, like Tracy and Adele, and together with Zohair. And even the Zohair presentations during the meeting in São Paulo, where he presented scientific aspects, and then he showed and he presented the future meeting that would be performed in Dubai, in Abu Dhabi in 2016, which was a huge success. It's very difficult to make a long story short, and of course Zohair has a lot of things to talk about, but I'll try my best. This is the young boy Zohair. It's a very handsome boy, and here is the graduation in the first group of the first medical school in Saudi Arabia, where Zohair is. Sorry, Zohair, I tried to look for you, but I couldn't find exactly where you are. But you are here, I know. And this is the assigned during a surgical residence. Zohair was assigned during a surgical residence to a team from Houston that started open heart surgery at the King Faisal Hospital in Riyadh. And what I talked to Zohair is that from this moment came his interest in cardiac surgery. He was a resident, and after that, he decided to be involved with cardiac surgery. he was a general surgery resident in Houston, and after that he trained in cardiac surgery in Canada, in Ottawa, and 1 year in Denver working with congenital cardiac surgery. When he returned to Saudi Arabia in 1985, he initiated the congenital heart surgery program, and here is Zohair in different stages of his life, with beard and mustaches, and with no beard and no mustaches, and always being very friend and with the children that he continues treating during his whole life. The King Faisal Hospital recruited Dr. Carlos Duran for many years, and after the Dr. Duran left in 1997, Zohair became the chief of the Department of Cardiovascular Diseases. And after that, in 2004, there was the inauguration of the King Faisal Heart Institute, where Zohair took a very important position and is being kept till nowadays. I saw in a poster outside here in the meeting, there was a picture of Zohair with a reference of the first open heart surgery here in Morocco, with the collaboration of Dr. Zohair Al-Halis. But before this, and many years after, he took part of many missions to Africa, Middle East, and Asia countries to help them, to teach them, to help them to structure as many of the surgeons here, but he had a very important role even here in Morocco and in countries from Africa. And these are some of the missions in Asia, in Thailand. There are other countries that he visited. But you might know that the only place where success comes before work is in the dictionary. You might work hard, you might produce, you might offer the best of you. And this is, you can see, a resumed curriculum of Zohair with close to 500 presentations and invited lectures, more than 400 articles and chapters published, and more than close to 150 abstracts presented and published. His special involvement is with the ROS operations, and he has more than 600 cases, personal cases. And here is Dr. Zohair with Dr. Donald Ross, one of his surgical mentors in special in this aspect. He took part of many international conferences and international committees with surgical demonstrations in Wspchs. Here are some friends, Sunji Sano, Krishna Iyer, in the back, in the bottom, Roger Me, and I could not identify everybody. And he took part of many important committees, like the World Congress of Pediatric Cardiology and Cardiac Surgery, in one of the steering committee meetings that was in Baltimore, and I was present together with Zohair. And also in many of the World Society of Pediatric and Congenital Heart Surgery Governing Council meetings, and in all our meetings in the past. The effect of all this fantastic job and fantastic involvement of Zohair was the recipient of many awards. So I, as a distinguished scientist, as an award by the province of Asir inside Saudi Arabia, and as a medical personnel excellence award, he received from the Sheikh, the distinguished personalities in the Arab world, the High Civilian Award in May 2007 from the King Abdullah, and the Takrin Humanitarian and Civic Services Award for the Arabic community that he received in 2017. Of course, besides all of this, there is a strong and very well-structured family. And here is Zohair with his wife, Hafsa, that supported him in all stages of his life. And they have 4 kids. One of them is Zina. She's a medical doctor, dermatologist, and here is she receiving the certificate, the conclusion of the fellowship, and she was honored as the best resident teacher during the program in Canada with the McGill University. Here is Sarah, and then she's here in the first line. I had the opportunity and the pleasure to meet her yesterday and to talk for some moments. And Zohair has a son, Abdullah Rahman, sorry. Is that correct, Zohair? Abdullah Rahman, who is also a medical doctor. He's a radiologist. And there is Dana, who's a medical student finishing the medical school. And here she presenting a poster in one meeting. Of course, life is not only work. Zohair has the opportunity to be present in many social, sports, and leisure moments. Here is in the left, Zohair in Barcelona, in one of the Barcelona games with the whole family. And here are some of his passions. Was sailing with friends, swimming with dolphins, fishing, and jet skiing. That seems is one of his preferences. What makes a true leader? I think it's competence, leadership, recognition, respect, intellectual honesty, and passion. And I think this is the biggest passion of Zohair, which is surgery. And I have the pleasure to introduce Dr. Zohair Al-Halis for his presidential address with the title My Islamic Heritage.
Thank you, Marcello, for the introduction. It's a great pleasure and honor to be here. First, I would like to say that I thinking really very hard about the title of the presentation, and one has really many kind of ways to think about it. But in general,